the American Society of Clinical Oncologists refers to precision oncology, also known as precision cancer medicine, as the evolution of cancer care. And it's important that you think of it as a kind of a living, breathing, organic thing that's constantly evolving and constantly growing. Just as there was a time when we had no treatments for cancer, and then chemotherapy and radiation and various other things came along, now we have the capacity for to test for thousands of genes that might be mutated and causing your cancer. And pharmaceutical companies have made literally hundreds of different types of treatments designed to target those mutations, and more are literally coming out every week. It's really exciting times, if you can use that word in association with cancer care, because of how many new treatments are coming out. And how those treatments are benefiting patients in terms of how much longer patients are living and how much fewer side effects they're having during and after treatment. So we're here to tell you a little bit about what precision cancer medicine is. If you're curious, we are located in Canada. That's where we began 12 years ago. But we support patients all around the world. And certainly precision medicine is available in most countries around the world if you know who to ask and how to ask. Okay, so I was telling you at the beginning of our chat today that oncologists think of precision cancer medicine or precision oncology as the evolution of cancer care. And that really, I just want to articulate again, we're not talking about alternative treatments. We're not talking about experimental treatments. We're talking about treatments that are in clinical oncology studies proven to provide better outcomes for patients than what is currently offered for that type of cancer in standard care. So it is this organic growing thing constantly. And what we're talking to you about or about to share with you today will almost certainly become standard of care in 5, 10, 15 years, but we're talking to you now. And that means it's something that you need now. And so that's why we want you to know about it and how to get it.
Yeah, and if I could add to that, you know, since we've been able to map the human genome, the DNA of the human genome, which was about 2006, 2005, 2006. Since then, we haven't really developed any new chemotherapy agents. Everything has been based on targeted therapies. You know, targeted therapies that target specific molecular features of a cancer. And this is what precision oncology is determining what is causing a specific person's cancer and targeting just that, and not randomly killing every cell in the body, such as chemotherapy does. And, you know, I like to look at precision oncology as the right drug for the right patient at the right time.
Yeah, so it's very personalized. That's what the precise means. You know, that we're using far more accurate tests. The PET-CT is so much more accurate than CT, for example. And what we're about to talk about in terms of genetic testing is so much more accurate in terms of dialing into what's caused your cancer than standard pathology and diagnostics, for sure. So that's very precision, but it's very personalized to you and your tumor and what's actually caused your cancer. And that's what also helps to make the treatment so much more beneficial, for sure. Okay, so there's essentially 4 key elements to precision oncology. There's the genetic and molecular testing that needs to be done in order to find out what's actually caused your cancer, because every cancer is different. I've heard oncologists refer to this concept as thinking of these things as snowflakes, that every person's cancer is as unique as a snowflake. They're all different, and slight variations make a big difference to the outcome. So the genetic and molecular testing helps to make sure that we've identified all the different pieces of your snowflake. And then there's personalized research. We have to take that information that we've gathered from those diagnostic tests, and we need to actually look at what it turned out for you and identify which treatments will be best for you specifically. And that culminates in pillar 3, which is a targeted therapy treatment plan. And then we can use some very leading edge technology, a very personalized genetic blood test actually, to keep an eye on your treatment and see how well it's doing. And with 99% accuracy within just a few weeks of you starting treatment. We have pillar 1 here, the DNA testing. Alex, would you like to say anything or walk us through this process about what genetic and molecular testing is?
So our human genome contains roughly 25,000 genes. Not all of those genes are required for the cell to function. Typically, certain cells have certain genes turned on, and other cells have different genes turned on. And you know, to produce different tissues, our bodies use different genes, but they use the same genome template of 25,000 different genes, and certain genes will create a blood cell versus other genes that will create a skin cell. So in general, we have 2 types of genes that are involved in cancers, and we like to call those oncogenes and tumor suppressors. Basically, what oncogenes are they're genes that are turned off typically throughout most of your life and only turned on when they're required to fix damaged tissue. So they're typically genes involved in growth and development or repairing damage to tissues. And we like to look at the genes involved in cancer as what we call wound repair genes. So let's say you cut your hand, then the stem cells very close to where the cut is will get turned on temporarily. They will produce a bunch of new skin cells. Those cells will differentiate into the type of cell they're supposed to be, and they'll be used to replace the damaged tissue. And then those genes will be turned off, and they won't get turned on again until you need to replace tissue. Those are referred to as oncogenes, or genes. Oncogenes are basically these genes turned on inappropriately. So in cancer, what happens is these genes are turned on consistently, and at that point they're called oncogenes. So before that, they're just called DNA, or they're basically called housekeeping or wound fixing genes, mm-hmm. or developmental genes, and they're only used at key times in our life, and that's the important aspect. So what happens in cancer is they're turned on and they're not able to be turned off, or they have mutations that causes them to keep a signaling cascade turned on constantly, called constitutive activation. The other class of genes that we have that are altered in cancers are what we call tumor suppressor genes. And tumor suppressor genes, basically, they will prevent cells from reproducing if they're growing too fast, or if they have damage to their DNA, if they have too many mutations, or if something's going on that's not supposed to be going on. And there's a whole bunch of different genes that repair DNA and fix mutations and prevent our cells from progressing and transforming into cancer cells. Just so you know, it takes roughly 4 mutations to turn a normal cell into a cancer cell. Now, these mutations can be any type of mutation in a set of specific genes. So when I say that, I would say that you have mutations in 4 different pathways, and just one mutation in each one of those pathways can cause a normal cell to become cancerous. In mice, it's 3. They have what's called an active telomerase. In humans, we have to have our telomerase gene activated in order for it to become a cell become cancerous.
So right now there's over 7,000 different types of genetic tests available. Not all of those are specific to cancer, but many are. They might look at one gene, or they might look at hundreds or thousands, but that's a lot. It's important for you, if it's something that you're thinking about doing, to understand what it is you most need to make sure that any genetic testing you have looks at. There's some key elements that you want to be looking at. I feel compelled right now to just mention a statistic that helps you understand the complexity of cancer care. As we go into treatments, you'll understand this even better. A recent study was specifically asking medical oncologists in the United States, where genetic testing it's used, there's 3 countries in the world that are really on it, essentially, or at least farther ahead than most, and that would be the UK, Australia, and the US. The question was, of these medical oncologists, really, how well educated do you feel and how confident do you feel in your ability to know when a patient needs genetic testing and how to apply the right targeted therapy or immunotherapy or treatment options based on that testing? In the United States, the answer was 40% of medical oncologists felt like they had a decent grasp on that. So in a country that's more advanced than most others in this particular regard, 60% of medical oncologists, those are the ones on the front lines treating you, don't feel confident in their understanding of how and when to use genetic testing or genomics and treatments that are targeted therapies or immunotherapies. And I want you to really understand that, because if you take this information, you ask your doctor about genetic testing and you hear something like, oh, you don't need that, or, you know, we'll do that later, or something like that. I want you to understand why that's being told to you, why there may be a little bit of a contradiction in what we're going to share with you about how critical that is for you living as long as possible, versus what your oncologist might tell you. And we'll get into that in a little more detail, but I wanted to say that right here, right now, if you're starting to think about the importance of getting the most accurate diagnosis and the right treatment plan, and you start to think about genetic testing, these are the things that you need to know, because your doctor won't actually very likely understand these things. But the more confident you are, the better able you are to advocate for yourself. So these 3 key elements, Alex is going to talk us through: fusion genes, mutation, and overexpression. It's all gobbledygook right now, but in about 5 minutes, it'll be clear. Alex, tell us about fusion genes.
So fusion genes are a relatively new finding in terms of genetics. And basically what they are that genes have 2 different elements to them. They have the coding region that makes up what the gene produces, you know, whether it's, keratin for the nails or whatever it may be. And then they also have the regulatory region, which basically is like a light switch that turns the gene on and off. And so, as I mentioned, there's certain genes that are supposed to be turned off most of your life, and they're only turned on briefly. And when they're turned on, they fix damage and they produce, basically they cause the cells to grow and copy themselves so they can replace damaged tissue. And then we also have these genes that are supposed to be turned on all the time. And, they're the ones that are surveilling your DNA, making sure that there's no damage, fixing mutations to DNA. And they're referred to as DNA repair genes and housekeeping genes. They're supposed to be turned on all the time. So what a fusion gene is these 2 genes actually meet up, and it's by accident. They get too close to each other and they stick together during reproduction of a cell. And what will happen is the control region of a gene that's supposed to be turned on all the time will accidentally get attached to and will replace the control region of a gene that's not supposed to be turned on, like a growth and development one. So let's say you have a gene that causes your cells to grow and copy themselves. It's only supposed to be turned on when you need to replace damaged tissue. And all of a sudden, you get this housekeeping gene or tumor suppressor gene, and the control region of that tumor suppressor breaks off and gets attached to this other gene that's not supposed to be turned on. Now you have a gene that is constantly telling the cell to grow and copy themselves when it's not supposed to be. And it won't have all of the other genes there that are involved in telling that cell to turn into a specific type of cell. Mm-hmm. So basically you get this massive amount of a gene or a cell type that doesn't really have any real definition as to what it is. It's not really a skin cell, even though it was probably produced in a skin gene or a gene inside of a skin cell. And it doesn't produce actual skin cells. It produces kind of like a naked bald cell without any definition. Mm-hmm. And that's because it hasn't gone through the process of differentiation. So it hasn't turned into the type of cell it is supposed to be. It's more like a stem cell or a precursor cell that hasn't been given all of the cues to turn into a certain cell. Now, there's two things that can happen there. Number one, the cell is not given what's called a Hayflick number. And Hayflick number is when a cell becomes, it's called programmed death. And basically what a Hayflick number is it tells the cell how many times it can copy itself until it is broken down and recycled. And so that's going to vary between every cell. Some cells live a long time, other cells live like 2 or 3 days. So that Hayflick number determines that. So when a cell doesn't have that Hayflick number, it can live forever. Additionally, because now you've got this active gene causing this cell to grow and divide, but it doesn't have all of the other genes turned on that are supposed to be turned on that tell it what type of cell it's supposed to be, then it's kind of like a naked bald cell that is constantly growing, and it can live anywhere in the body. It's not restricted to a certain tissue. And basically, this is what we call cancer. So a fusion gene basically causes cancer in that manner. And fusion genes are going to be more and more important as time goes on. There's many new medications being developed just for fusion genes. When a gene gets mutated, and once again, we have the two different types of genes. We have the oncogenes that are turned on when they're not supposed to be, and we have the tumor suppressors that are turned off when they're not supposed to be. And so a mutation in a tumor suppressor gene basically prevents its function from working. So it can't fix the damage, or it can't prevent that cell from growing and dividing, like a checkpoint gene, for example, a gene that prevents a cell from growing and dividing if it has an abundance of mutations or if it's growing too fast. One of the common ones that we look at is called the BRCA1 and 2 genes, and they're involved in that process. They're involved in the DNA repair process and recognizing mutations and preventing cells from growing. So when you have a mutation in those genes, they can't actually do that, and cells that are damaged and have mutations can then go on and grow and copy and divide and turn into cancer cells. The other type of gene is obviously oncogenes, and typically the mechanism for an oncogene is it will cause it to stay turned on permanently, or other mechanisms, it will attach to its binding partner and get stuck to its binding partner, or it will have a new binding partner that it's not supposed to attach to and cause signaling in a manner that it's not supposed to. And usually these signaling pathways are going to be involved in growth and development and copying of the cells and, metabolism. So mutations in oncogenes make them overactive, and mutations in tumor suppressor genes cause them to be damaged and not function properly. I think the most interesting new development, and this is relatively new in clinical cancer care, but it's been around in research for a long period of time, is overexpression. And overexpression is the switch that's in front of the gene. And so you don't have to have mutations or damage to the switch. The switch gets turned on too much, like it gets turned on when it's not supposed to, or it gets turned off when it's not supposed to. And this is how epigenetics work. So what epigenetics are, and I touched on this briefly earlier, is we have roughly 25,000 different genes, but they're not all turned on at the same time. You don't need them all turned on at the same time. We have genes that we don't even use. And so what epigenetics is epigenetics is the process of turning genes on and off. And one of the general themes of it is what we call promoter methylation. The promoter is the region of the gene that controls whether it's turned on or off. And so when you have methylation on something called CpG islands, in most cases, what it does is it prevents the transcription machinery and translation machinery from binding onto the gene and turning it on. And so loss of methylation means that that gene can be turned on because nothing's blocking the transcription and translation machinery. So what happens there in epigenetics is our body will turn on different genes to produce different tissues. And certain genes will be turned on longer than they are. So for example, let's say you have a skin cell and a certain set of genes needs to be activated for a longer period of time and turned on longer to produce more of the genetic product. than, let's say, in a bone cell or, a blood cell or something. So epigenetics is merely just a way of creating a multi-tissue organization structure out of the same 25,000 genes. It's just turning on different genes on and off. Now in cancer, what can happen is you could get changes in these methylation of the promoter. Certain genes, such as tumor suppressors, can get turned off. They can have methyl tags added to their promoter, and other genes can have their methyl tags removed, so they get inappropriately turned on when they're not supposed to. So overexpression is a really important thing to look at, because not all mutations cause a tumorigenic activity. And when you look at mutations and overexpression of genes together, then you really get a full idea of whether that mutation is a cause or driver of that cancer and whether that should be the target of treatment.
That's a good point that, again, the cancer is evolving, or cancer care is evolving. And we started with tumor DNA testing. This overexpression testing is very, very new. The concept is, or understanding it in relation to cancer is new, and the application is literally 2-3 years old.
Yeah.
So it's very new. But the point you're making, I think, is an important one, because those of you watching may already have had some DNA testing, or your doctor may have tested for certain cancer markers, which just because you have those mutations, what Alex is saying is that doesn't mean that those mutations are driving your cancer or are the ones that you most need to target for the best outcome of your care. So the combination of the tumor DNA testing and this overexpression testing really gives you a much finer point, or a much more accurate assessment of what's driving your cancer for targeting. And these 3 tests in combination will help make sure you tick all those boxes. So there's tumor DNA testing, RNA expression testing, and inherited mutations testing.
We've discussed basically tumor DNA testing and RNA expression testing. So tumor DNA testing is where you isolate the DNA from the tumor and you look at that, but it's specifically just the DNA from the tumor. Whereas inherited genomic testing looks at the DNA of your normal cells, and it looks for any inherited mutations that could give you a sensitivity or a sensitivity to certain types of chemicals. Typically, we look at what we call mutations, inherited mutations in DNA repair genes and so on. So if you're born with a mutated BRCA1, then that means you can't fix certain mutations and you have a higher chance of getting cancers in certain tissues. So tumor DNA sequencing, basically what we do here is we'll take a tumor sample and we will isolate the DNA out of that tumor sample. And then we will we'll isolate the RNA as well, but in this particular case for tumor DNA sequencing. And then we'll look at a panel of anywhere from 100 to 500-600 different genes that we know are involved in cancer and that can potentially have targeted therapies for them. And we'll look for mutations that have what we call indicated targeted therapies. So in other words, drugs that that are designed to specifically target that mutation.
As we were saying earlier, this piece of data alone gets you in the ballpark, but doesn't necessarily hit the bullseye, because just because a mutation turns up in your test doesn't mean it's a driving force of your cancer. And this RNA testing.
With RNA testing, it's really developed recently. So what we do is we take a sample of the RNA from the tumor, and we look at the expression of over 20,000 genes. It's about 22,000 that we look at right now. And we compare that to a sample using the same panel and the same conditions of normal tissue. So let's say you have a lung tumor, extract the RNA from that tumor, And then we'll look at the 20,000 plus genes in that tumor. And then we'll use the exact same testing techniques to look at normal tissue. And we'll compare the two and see what the fold change is. In other words, what genes are overexpressed. And when we see a gene that's markedly overexpressed, then we know that that's a driving gene in that particular tumor at that time. And we can target that with a drug that lowers that particular gene product. Mm-hmm. Now, we don't always have a drug for that, but usually there's so many different overexpressed or underexpressed genes in a tumor, there's usually a variety of different options. So this really does open up a lot of different options that DNA sequencing doesn't.
You were talking earlier about inherited mutations. Anything you want to add?
Yeah, I think one of the big things with inherited mutations is we used to think that they were, not very common. And that's because we didn't look at very many genes. We're starting to see now that there's a variety of different ways cancer can be inherited. So typically, when we look at inherited mutations in the traditional sense, and this is in the field of genetics, standard genetics is what I call it. We'll look for certain key genes like tumor suppressors and so on that are in our, what we call our germ cells, the cells that will be passed on, inherited. And so, if a father, for example, has a BRCA1 mutation, then the kids have a certain percentage of catching that mutation. So we have 2 copies of every gene. And, in a general sense, I like to say, you got 1 copy from your mom and 1 copy from your dad. And that's not necessarily true for all genes. Some genes, that is the case. Other genes, it's not the case. But the bottom line is you have a particular predictive chance of gaining a mutation from one parent. Now, there are something else that we see. This is called, traditional inherited mutations. Happens in maybe 5%, 6% of all cancers. Typically, we see this in people who have cancers under the age of 50. However, what we're seeing a lot more of, because we pretty well test most patients that we see under the age of 50, we test them for inherited germline mutations, and we don't always see that. But what we do see is we see a type of inheritance that's very similar to other genetic diseases, such as Down syndrome and Reye's syndrome, where you have a change in the chromosomes. You can have an additional chromosome, or, we see that sort of process happening in cancers where either the gene, a gene in either the egg or the sperm is actually damaged. And it's only damaged in that one egg or that one sperm. And what happens there is we'll see this kind of one-off inherited mutation. In other words, the person was born with a damaged gene, and that caused them to get cancer before the age of 50, but they don't necessarily pass that on because it's not in their germline cells. And this is very common, with Down syndrome, is where healthy parents can have a Down syndrome baby, and Down syndrome parents can have healthy babies. So it's kind of a one-off where, the egg is damaged, something happens to the DNA in the chromosome somewhere along the line. One thing we do know is that so one of the first things that develops in a female after conception is the eggs. And so the eggs, basically get created in the mother first, and then the daughter grows and carries on those eggs. So what happens? So for example, if we see this type of cancer in a patient, let's say, a 25, 30-year-old woman, and she gets breast cancer, and there's no cancer in her immediate family, such as her mother or father or brothers or sisters, then often we could assume that the damage occurred in her grandmother. When her grandmother was carrying her mother, something happened to the egg that created this child. So it skips a generation typically.
We talked a little bit about biopsy and pathology earlier when we talked about standard care. But one of the things that is naturally happening as this evolution of cancer care is occurring is that the procedure for taking good biopsy samples, handling them carefully enough, and the actual procedure of the testing process also needs to evolve. Because the current process, which was perfectly fine for standard pathology, just staining for malignant versus benign and a few other things. I know I'm simplifying, but generally, the current procedure is perfectly fine. The surgeon takes some sample, puts it in a dish, sends it off to the pathology lab. They do their thing and they can tell you, is it malignant or benign? As we're wanting to do more delicate and refined testing, down to the molecular level, we are running into some problems now where in most genetic testing services, 40% of the time a test will fail, or unfortunately the patient gets a note saying your sample failed. Like, it's not bad enough already. My tumor is failing. The point is it was too degraded. There was something, not enough tissue, or it was too degraded to be able to produce a viable test result that the company could have confidence in. So that's 40% of the time. It'll be a while before surgeons and pathology labs are set up with the technology that they need to change that number and make it so there's hardly any samples that aren't providing good efficacy for testing. So what we do right now in order to get around that, Alex, would you like to tell us a little bit about this new technology?
The standard approach of storing tumor samples in FFPE, formalin-fixed paraffin-embedded tissue, it results in degraded RNA specifically, and to a certain degree, degraded DNA. Now, a lot has to do with how long that tumor tissue stays outside of the body before it gets put into the sample, and how that sample is stored. There's many different things there. But in general, what we've found is that a lot of the samples fail. So we used to use independent labs all the time. We use CDX, Foundation One, Caris, all of the different commercial companies out there. And we, did RNA testing as well. And we saw a lot of failures. In other words, we'd have this tumor sample and it'd say, sorry, there wasn't enough, it was an insufficient amount of DNA, insufficient amount of RNA, it was too degraded. And patients are waiting on these tests for treatment options. And sometimes, having these tests is really important for patients. In fact, all cases, it's really important.
It is really important, yes.
So having a good sample is important. So what's happened with the technology? Now, I love Foundation One. I think they're an amazing company. They've done some really incredible things. They have one of the first FDA-approved genetic tests, the CDX, and it's a great panel. But the problem with an FDA approval of a test means that test can't change and adapt. And so once that test was actually FDA approved, then just merely making a simple change in that test and adapting a new technology can cost millions of dollars. They have to prove that it works and everything. Whereas the researchers have been able to benefit from, magical changes in tumor DNA sequencing and RNA sequencing. And it's just been consistent. Every few months, a brand new technology comes out. Mm-hmm. So now we have the technology to isolate tumor samples from degraded biopsies. And this uses a laser-based technique and something called a PEM membrane slide. And so we use a special pathology company in the US that is able to get us highly purified samples of tumor DNA and RNA. And this really changes how our results work. One of the most important things about tumor DNA sequencing and RNA sequencing is having a purified sample. So the techniques of standard pathology, often they're dealing with a biopsy sample that may only have, 25% of the cells in the biopsy sample are tumor cells. And so they look at these two, they put them on slides, they stain them, and then they cut them out with the scalpel or, use various techniques like that. With the PEM membrane slides and the laser techniques, they can isolate highly purified amounts of tumor cells, and they can get data and RNA and DNA from slides that standard pathology techniques would not provide.
Yeah.
Additionally, the standard DNA sequencing process that is used for both RNA and DNA sequencing. One of the biggest companies is what we call Illumina. And they use a process where they create the samples called hybrid capture. And hybrid capture is a very time-consuming and difficult process to do. Additionally, you have to have a lot of material to be able to get any results. Whereas the new technique is a company called Thermo Fisher that we've invested in. And it's a great company. They have these robotic tools that will actually do everything for you. So there's hardly any lab work required. They have these amazing little chips. You get that isolated DNA or RNA, you toss it on the chip, put it in the machine, and then 3 days later you have your sample. You hardly have to do any lab work. But most importantly, they use a process that bypasses hybrid capture. They use a PCR-based process. Now, it has its disadvantages and advantages too, but the main advantage of this system is it's able to produce data in very poor quality samples or samples that don't have a lot of DNA or RNA. And this is why we like it. It's not that it produces a better result, it just is able to use more poorly degraded samples. And that allows a lot of that 40% of patients whose samples typically fail with the Illumina process in the standard pathology. This allows us to, get at least 30% of those patients get data for them. Mm-hmm. So it's a great advance.
Yeah. And when you understand that these, your biopsy sample and whatever genomic or molecular testing that you do, it's your ticket to options other than chemo and so radiation and, treatments that can target your mutations and help you live a lot longer. So it really is quite a critical element.
Yeah. And it also is able to, maybe in a degraded sample, you're not going to see all of the tumor markers in there that you will through using the better techniques.
A purified sample.
Precision oncology isn't just about getting the right drug for the right person. It's all of the techniques. It affects every aspect of the technique that helps you determine that.
Mm-hmm. How precise that.
It's not just a good drug. It's precision in every aspect of cancer diagnostics and treatment.
Mm-hmm. That's right. You can really fine tune everything and it produces a much better result. So the second piece, now that we've talked about all the different things you need to think about when it comes to genetic testing, what's possible, why you want to make sure that your sample is handled as well and tested as precisely as possible. What do we do with all that data? Well, that's where the personalized research comes in. This is where, again, it's so complex. Hundreds and hundreds and hundreds of pages of data get returned from these tests. And if you have both tumor DNA and RNA sequencing, or then add the inherited mutations in there, that's a lot of information. And your medical oncologist not only isn't trained to deal with that, as per what I said earlier about, only 40% feeling like they have some comfort with that, but they don't have the time. This is hours and hours of time. There's some wonderful automated services that do analyze some of this data. We can tell you a little bit about those in time. But generally, what you need to be making sure happens is that somebody takes this genetic testing and doesn't just prescribe based on the results of one test, but actually then combines all of the information, including your medical history, all of the mutations that were identified for you, either fusion genes, mutations, or overexpressed genes, how they might influence each other, which treatments have been designed to target those various mutations, and how they might work with each other, and therefore what combinations of treatments are most important for you to get on. These days, wouldn't you say, Alex, it's more common that the right treatment for somebody will actually be 2 or 3 treatments simultaneously, like a combination of treatment?
Oh yeah, for sure. With precision oncology, the goal is to turn cancer into a chronic disease where we just constantly find new drugs or treat with new drugs to target the new evolving mutations that the cancer's throw at us.
Let me also say, in response to what Alex said, obviously the goal is a cure. Oncologists are very reluctant to use that term, but
and so am I.
What we're, yes, of course, appropriately so. And what we're seeing, just to clarify, and when Alex uses the term chronic condition, imagine something that, you know, you need a couple of doses of treatment for, and then you can go on about your life for a number of years, and then a couple more doses, and so on. That's really what we're seeing, if not, again, long-term stable remission for a lot of patients.
Yeah, I like to use the analogy that I heard a few years ago. Think of cancer as a bus moving down a highway. So when the cancer is growing and metastasizing, it's like a bus that's traveling down a highway. You have a driver and you have a passenger. So in other words, the driver is the driver mutation at that given point in time, and the passengers are all of the other mutations that are not necessarily driving the cancer at the time, but we discovered them in the original tumor DNA sequencing or RNA expression. So we know who the driver is, and we have all these passengers in there, and we know who they are too. So what we do is we hit the bus with the drug, it hits the driver, the bus pulls over, the driver gets out of the driver's seat and goes and sits down in one of the passenger seats. After a while, maybe a year or two, one of those passengers is going to get up and he's going to say, you know, I think I can drive this bus. And they're going to get up into the driver's seat. They're going to start up the bus and start driving down the highway again. So then our job is to find out who that new driver is, which one of the passengers is now driving. And then what we do is we get a drug and we hit the bus with that particular target for that new driver. The bus will pull over, and that driver will get out of the driver's seat and go sit down for a while. And then another passenger will get up. So the important thing is, basically, tumor DNA sequencing and RNA expression testing is like having the patient manifesto of the bus. We know who the driver is. We know who the potential driver is. We know all the passengers, and we look at them all as potential drivers. So if we have all of that information, then what we can do is we can continually find treatments to help that person control their cancer throughout their lifetime. And so the term I like to use is not cure, it's durable long-term remission.
But that's a really excellent analogy, actually. And sometimes that bus can be pulled over for a very long time, is what I'm trying to say. Pillar 3 of 4, to do with making sure you're getting the precision cancer medicine, the best possible treatment. We've talked about it a bunch already today, targeted therapies, of which, you know, in my world view of understanding this, immunotherapy is a subset. And Alex will talk more about that in a bit.
Targeted therapies are basically therapies that target a specific mutation that we determine through tumor DNA sequencing or RNA expression testing or basic pathology.
I was talking with Dr. Roselle Kurzrock, who is a founder of CureMatch, which is one of those bioinformatic programs I was telling you about. That's just making it so much easier for us, and specifically medical oncologists, to take all that complex data that comes from genetic testing and make it something that they can actually process and utilize for you in a reasonable period of time. She used the analogy of smart bombs. For targeted therapy, how, you know, you can think of it as a smart bomb that's designed to go into the body and target just that one particular mutation, that one particular part of the cell. And because of that, it's so much more effective in terms of hitting the target, but also a lot less collateral damage. I thought that was a great analogy.
Yeah, great analogy. Yeah.
So off-label cancer treatments, I just wanted to throw this slide in here and just mention it because it's something you might see if you're on cancer self-advocacy sites or different support groups and things like that. People might be experimenting with off-label treatments. What I most want you to understand is off-label treatment doesn't mean experimental. It actually means a drug that was designed for something else, but that we have some proven efficacy for using for this thing as well. That's what off-label means. But before you just go ahead and try something that you see on one of these support groups or you know, cancer support programs, it really, again, is important that you've had the testing to understand the mechanisms that are driving your cancer. For example, metformin is one, in my exploring of some of these cancer support groups that gets tossed around a lot. Try this helps. Well, maybe. It depends on what's actually going on and what's actually driving your cancer. Metformin is a drug that was designed to treat diabetes and works quite well for type 2 diabetes. And it can provide some benefit for some patients with the right genetics. But you certainly wouldn't want to just use that because somebody on your cancer support group suggested it worked for them. Okay, you've got to understand the mechanism. And then once you can prove the mechanism, your oncologist would probably happily prescribe you one of those off-label treatments. But without it, it wouldn't be smart for them to do that. So that's why sometimes patients think, oh, my doctor is resistant. Well, maybe, but it might also be that you haven't, there's no reason for them to assume this treatment would work for you. And you have to collect the data to prove it. And that's what that genetic testing and RNA expression testing we're talking about will do for you. Yeah.
And so in the case of metformin, it's mTOR.
That's what it targets?
Yeah.
Yeah. So if you had a mutation in your mTOR gene, is that a thing?
Yeah, yes. Overexpression of the mTOR pathway in general.
Thank you. Overexpression. So if you could prove that you had that, then your oncologist would be able to connect the dots and say, oh yes, there's these studies that show that this drug targets that pathway. So of course I'll prescribe it for you. Otherwise, it would be malpractice for them to do that, actually.
Basically, what the concept of immune therapy in cancer is all about is cancer cells hijack the immune system. And that's because they use the same foods and the same resources. So they're very similar. Active immune cells and cancer cells share a lot of the same similarities. They're constantly growing. They're highly metabolic. It's just that the immune system is supposed to attack cancer cells. So right now we know of about 14 different pathways that the immune system uses to turn off the immune system or the cancer cells. The most common one is called PD-1, programmed death 1. We also have drugs that target CTLA-4. And now we have drugs that target EAT02. And I believe there's a few other drugs in development as well. So in short, PD-1 inhibitors, what they do is they soak up the free-floating PD-1. PD-1 is something that tells the body not to attack it, and cancer cells overproduce it. So in PD-1, so typically if you're going to respond to a PD-1 inhibitor, in many cases you have to have high PD-1, but that's not always the case. Well, it's different in different cancers. We know in some cancers, high PD-1 will determine whether the drug can be used by itself. And in many of those cases, if the patient has low PD-1, that just means we need to add other drugs like chemotherapy drugs or targeted therapies that will also work in synergy with immune therapy. Typically, there's certain cancers like lung cancers, and in this case, bladder cancers, that if you do have high PD-1, then it definitely means that these drugs are going to work a lot better for you. In other cancers, it's how many mutations you have, called the tumor mutation burden, and whether you have something called microsatellite instability, or whether you have damaged mismatch repair. There's another gene, PALB2, if you have, if that's damaged. Basically, if there is some sort of genetic alteration that makes your cells look different to the immune system than a normal cell, then the immune therapy can be of some benefit. And what you're doing is you're basically reactivating the immune system because it's been turned off in the tumor microenvironment, and you're reactivating it and letting the CD8 positive T cells recognize the tumor for a tumor and not just as a regular cell.
That's excellent. That's again, that one piece is so complex. The point I was hoping to make there is back to that statistic I was saying earlier about only 40% of medical oncologists, and a country that's more used to using genetic testing feel comfortable in their assessment of the data. So if your oncologist says, well, you don't have high PD-1, or, you know, it was kind of low, so immunotherapy won't work for you. Alex just listed numerous other indicators that should be considered. So don't take that as a no. It means, oh, we need to get a little more data to make sure. In addition to the hundreds of targeted therapies that are out there right now, plus numerous different off-label options and things like that, there are more than 100,000 clinical trials for cancer in the world right now. Clinical trials today are not what they used to be in terms of the experimental nature. A lot of times, by the time something gets to a clinical trial in this capacity that we're talking about, this 100,000, the efficacy of the treatment has already been proven. And what they're looking to assess right now is the proper or necessary dosing for people. There's so many perks associated with clinical trials, and access is so much easier. You don't have to be in the country where the clinical trial is being held. Lots of details on that, should that come to pass for you and be something that you need to explore. Within 15 minutes, you can identify which of those 100,000 clinical trials is right for you, and which is accepting people, and how to apply. And you can even have someone help you with all of that process for free. So don't get stressed about it when you see a big number like that. That's just something I want to say. It's very rare, actually, that our patients need to explore clinical trials. There's so many options out there right now. But I really did want you to know that there really are, again, so many options. And accessing something like a clinical trial is easier than ever before, free, and there are support services to do that. And we can certainly connect you if that's something that you're interested in. The last pillar of this precision cancer medicine process is using the most advanced approach to monitoring how well your treatment is working. So if we go back to what we were saying earlier about CT scans being the standard for monitoring, and CT scans require numerous scans over time to be able to see if there's been any sort of change. Mm-hmm. And again, they cannot differentiate between live and dead tissue. So they're not a great approach for this. There are certain types of cancer treatments, as immunotherapy specifically, that influence certain ways that cancers will show up on certain scans. And so one of the best approaches and most, we'll say, emerging technologies for treatment monitoring is called liquid biopsies. So there's a type of liquid biopsy that is used for diagnostics, and that's like a tumor DNA, but with blood. We're talking about using blood-based tests for monitoring, which is a little bit different.
Yeah, so tumors release their DNA into the blood, and so do normal cells. And this is good because we can use that for diagnosing things, not only for identifying emerging new mutations. We can also monitor whether treatment is working very quickly. So tumors release their DNA through a variety of different processes. One of them is through apoptosis, programmed cell death. Another way you can isolate tumor cells in the blood when you're drawing it without even knowing it. And then also through the process of exosomes. Tumors release some mutations and some DNA, mostly RNA and proteins, through a process called exosomes. And what's more interesting is we've found that these exosomes are involved in metastasis specifically. And so DNA tends to stick to the outside of these exosomes. So we call it exosome-associated DNA. And we don't know if there's other vesicles that are used. It's a complicated field. We're still learning a lot about it, but we do know that the DNA that's involved in metastasis occurs at a certain size. It's broken into little pieces at a certain size. So what we do is we isolate that DNA that's associated with metastasis. We isolate it from the blood, and we can test for mutations that are unique to a person. So let's say a person has a KRAS mutation. It's not a mutation we can target right now. There's no drugs that target it, but we can definitely use it as a surrogate to measure the amount of the disease. So let's say the patient's trying a new drug and they want to know if this is the right drug for them. They don't know for sure. So typically what would happen is they'd get on the drug. The doctors would do a CT scan before they start, or use a CT scan that was done before they start. And then 4 months later, they'd do another CT scan. Well, 4 months is a long time to go to determine whether that drug is working or not. And more importantly, if it's not working, then the tumors could be all over the body by then. And then even more importantly, if the patient is paying for the drug out of pocket, they've spent a lot of money for nothing. So being on the wrong treatment is not a good thing. You want to do everything you can to determine whether you're on the right treatment or not. And so this is a good way of doing that. And so what we do is we measure the amount of that tumor-associated mutation in the blood right before treatment. And then within about 2 weeks after treatment, we measure it again. And if it's gone down, we know the treatment's working. If it's gone up or is the same, then we know the treatment's not working and it's time to go to something else. So we don't have to wait for that 4 months. So one of the best tools, in fact, one of the reasons we developed this test was in immune therapy, certain patients have what's called pseudoprogression. And so about 30% of patients on immune therapy will experience pseudoprogression. What pseudoprogression is the immune cells will reproduce inside of the tumor when they're activated. So the CD8 positive T cells, the CD4 positive T cells, so the TILs and the regs, tumor infiltrating lymphocytes, CD8 positive cells, and Tregs, regulatory cells that are involved in an immune response process, but also feed the cancer, are called Tregs. They're CD4 positive. And then various other cells, fibroblasts, macrophages, and so on. All of these will expand within the tumor. And when that happens, and in response to immune therapy, that means when the immune system is turned back on after being turned off with a drug such as pembrolizumab or nivolumab or a CTLA-4 inhibitor such as ipilimumab, what happens is these immune cells become active, they copy themselves, they grow, they expand, and they make that tumor look much bigger and it expands. And so when we first started using immune therapy, we would see this massive expansion of all of the tumor cells in the body. And then also we'd see new tumor cells or new tumors show up that weren't there, even 2 weeks ago. And so what was actually happening was the immune system was going in there and killing the tumors from the inside out and expanding within the tumors. And then also imaging can only see tumors as small as a couple millimeters. And so there were tumors that were sub-imaging size. And then when they got bigger, all of a sudden you're able to see them. And so it looks like you have new tumors, but really those tumors were there before, they just weren't able to be seen through standard imaging. So then what doctors did is they used PET-CT and they said, okay, we'll figure this out with PET-CT. But unfortunately, the immune cells drink up a lot of the PET-CT fluid too. So it looks like they are active. And so you can't even use a PET-CT to determine whether these immune cells are killing the tumor or not, and whether the patient's going through pseudoprogression. So what we did was we looked at the amount of tumor DNA. And sure enough, in a patient is going through pseudoprogression, it'll look like their tumors are growing. The PET-CT will look like their tumors are growing, but their percentage of their driving mutation, like the KRAS mutation, will go down. And so we've been able to keep many patients on immune therapy where their doctors were about to take them off, thinking they weren't responding when really they were just having pseudoprogression. And vice versa. We're able to say to doctors, the percentage of this patient's driving mutation has gone up since they've been on immune therapy. The immune therapy is not working. So, time to take them off that.
Yeah. So such an important tool to have for that very reason. Because you want to, if your treatment's working, you want to know. If it's not working, you want to know. And certainly you want to be able to stay on it if it's giving you benefit.
Yeah. And we can also detect tumor activity before it can be seen on imaging. So we had a patient recently whose imaging was clear. And then we started detecting a small rise in their ctDNA of their mutation. I believe they had a KRAS 13G mutation. And I sent that to the doctor, and the doctor said, oh, that's strange. They get their imaging every 6 months. The last imaging just 3 months ago was clear. And so I said, well, maybe it's time to get some more imaging. So the doctor got the patient more imaging, and they found that they had tumors all over their body. So the liquid biopsy was what precipitated that. And had we waited for another, 3-4 months, it would have been too late. But at least now we caught it, right before all hell broke loose, so to speak.
Yeah. It can grow so quickly. Really, it's remarkable, isn't it?
It is, yeah.
Yeah. So we've discovered that, or discussed that cancer is caused by genetic mutations. There's different ways that might show up, as we talked about, with fusion genes and mutations specifically, and overexpression that can influence so many different things that can cause those cells to just keep replicating themselves, and tumors grow and make it hard for your immune system to find them. And it's sneaky stuff. But we have so many different options now for testing and for treatment, for sure. The RNA expression testing that Alex was talking about looks at, you said 22,000 different genes.
Yeah, well, it's just under 22,000. Yeah.
Okay. So that's a lot of information. And again, helps you really get into that bullseye. I think the most important for you to know is a lot of those statistics that you're going to see in studies, or that your doctor might reference as what you can expect in terms of life expectancy, almost all of them are based on standard treatment and not the things that we've been talking about today. I wanted to also invite you to join our self-advocacy training program. Everything we've talked about today is something that we can help you with, and we can coordinate for you. It takes anywhere between 3 to 6 weeks for all the testing, the treatment plan, and for you to be on the best treatment plan for you. But we've also created a self-advocacy training program so that you can understand this stuff better and advocate for yourself, which makes it a little less costly for you. And again, just helps you to have more confidence in what you're doing. And knowledge is power, as we say so often in our work. And this is the best way for you or your advocate to have that knowledge. So I want to encourage you to join. There's a link at the bottom of the screen here that will tell you where to find the course if you want to go straight there and register. And you're also welcome to just email me directly at mmorand@ctom.com, as on the screen here. We have a live consult that we do as part of this program, in addition to all the videos and the lessons and all the downloadable PDFs you can take to your doctor for discussion. We also every Friday meet with folks who are members of this program to answer any questions they have. So it's a really great way for you to be able to get some expert advice every week and every step of the journey, and really drive the bus of your cancer care for yourself. And last but not least, I want to invite you, if you'd like to chat with Alex directly yourself, to visit this link, ctom.com/consultation. And that way you can get together and have a 1-hour consultation with Alex. He'll gather your medical records prior to the meeting, have a look at some treatment options for you, and come to the meeting prepared to talk with you about all of your options. You get a video recording and a written summary. We want you to have all of the information at your fingertips and not feel at all stressed or like you have to wonder, what did he say? Oh no, what is the name of that thing? So we provide you with a recording and a written summary. And both of those things can be shared with all of your family and other advocates and your doctor to help them better understand all of your options. Thanks for being with us today. We hope you found this really beneficial. Feel free to send us an email, ask us any questions that you have. We're here to help as much as we possibly can.